come right in. Yeah. This is the right place for your transcranial magnetic stimulation. Yep. Have a seat. This paper is to help us align exactly where we're going to be aiming the magnets. Because we want to hit your left dorsolateral prefrontal cortex for depression, obviously. But I know they already went over that with me before you even got started.
I'm going to need your head down a little bit. So I can match those. Can you slide down a little bit?
Is that good?
Yeah, that's better. Right there.
Thank you.
You're welcome.
And thank you for the Zoom link.
Oh, you don't mention it.
Yeah, this big thing is the thing that actually fires the magnets. The other stuff just helps keep you stable. Don't forget your ear protection, because it makes a loud sound in the same frequency all the time. It's like a tiny jackhammer on your brain. You're looking good. What's that? Are you having some anxiety about the treatment? That's fair. To tell you the truth, I'm actually going through it myself. I'm about a month in, and especially in the first couple of weeks, I was pretty anxious about it. Yeah. We can talk about it again. We don't have to turn it on until you're ready. By again, I mean, I know other people have talked about it with you, but you and I can go back over everything. You're just worried about risks and things like that. Well, we can go over the risk questions again. Yeah. I have a little extra time. Absolutely. Let me just adjust some things here on the computer. Just above you here. No, that's totally fine. You are totally fine. Well, as you know, it is treatment for depression that's been resistant to, more than one medication. Although the FDA doesn't restrict it to only people who failed one or two medications. Usually that's the only way insurance companies will pay for it. So, I know you can hear the hum of the machine, can't you? Is it bothering you? You just let me know, okay? Yeah, I can check this on your head over here. And over here. Is it okay? I don't want the hum to bother you. Okay. Yeah, we can go over the questions again. So, do you have any history of epilepsy? No. Okay. Any family history of epilepsy? No. History of seizures? No. History of head trauma? No. Have you ever lost consciousness? I don't mean like when you stand up quickly and kind of get black for a second, or like your vision goes out for a second and then comes back. I don't mean like that. And I don't mean sleeping or like getting blackout drunk or anything like that. I mean like we've actually like passed out. Okay. Any history of stroke? Any history of brain tumor? Traumatic brain injury. And that's one that, not necessarily a contraindication, but would be a reason to talk to a neurologist. A lot of veterans have experienced that, and that can be a cause of the depression, or it can be more likely, like if you hit your brain, you're more likely to have PTSD, depression, personality changes, because, the neurons are actually where the information is stored. You actually janked up the computer, right? Yeah. Any implanted metal devices or metal in your head? I have one of those dental retainers behind my teeth too. It doesn't matter. Those kind, they always make them non-ferromagnetic. I mean more like if you were deaf and you and your family had chosen to go for a cochlear implant, that would be a big no-no. So if you have any of those, it's not even necessarily a contraindication. It's just you would want to talk to a neurologist first. Yeah. Well, because the biggest risks that we're talking about, right? People who have metal in their head shouldn't have magnets, right? That makes sense. Or in your neck or stuff like that. Because they can heat up, and that can, do thermal injury to the adjacent tissue, and that would be a bad thing. What else? It could also make objects move, right? If you don't have metal in your head, metal plates, chips, electrodes, pumps, stimulators, pacemakers. Although pacemakers, that's usually metal implanted below the head and neck, like hip prosthesis or stuff like that. Generally considered safe because the magnetic field falls off pretty rapidly with the distance. There's an equation for it, which I'm sure you remember from high school physics. Yeah. What else? Sometimes if we don't know, then it's a good idea. Like if you have been shot, and we don't know if there's metal somewhere north of here, then we would get a radiograph, an X-ray. Mm-hmm. Exactly. There isn't much safety data for RTMS on like implanted vagus nerve stimulation and cardiac pacemaker devices. So in that case, we would then talk to a cardiac or a neurological specialist. But those are rare things. So that's the main thing. That, and then, things like seizures. Yeah, so the Journal of Clinical Psychiatry has actually like the big consensus guidelines that's been summarizing all of the studies that have been done on transcranial magnetic stimulation. Mm-hmm. Yep. And so that's a good place to look if you want more information on guidelines or things like that, right? So there's some medications like bupropion, which is a medication people use to stop smoking. It's also a depression medication. Those medications or other medications that decrease your seizure threshold, that can be something to think about, right? So we wouldn't want to change any medications during the time that you're getting RTMS, right? We want everything to be stable. So, that's the main, big scary stuff. But again, that's rare. Most people don't have a history of epilepsy. Most people don't have metal. But, those are the things to kind of be most, worried about, if you want to put it that way. So when we're talking about risk-benefit, kind of the question, and if you're using a lot of alcohol, substance abuse, that can, just like with any antidepressant, it can kind of affect outcomes, efficacy and stuff like that. Yeah. My experience. So let's talk about the science first, and then I'll tell you about my experience with it. Yeah. And why I got it. Or am getting it. Yeah. The reason I say to talk about the science first is because my experience is one person's experience, and everybody's experience is different. The benefit of clinical trials is you can look at many people's experience and therefore cover what you're most likely to encounter. There's always some people who are outliers, right? You could say that somebody has a 1% risk of seizure. Well, we don't know who is that 1% and who are the 99, right? And that's not the actual number. But, so that's why we check for family history and personal history, and that's how we find out who should or shouldn't get a treatment. Yeah, exactly. Because that's as close as we can get to narrowing it down. It used to be that people did general population medicine for everybody, and then there was a time when people were doing racist racial medicine, and then now people are more looking into genetic risk factors, right? So for example, when we talk about hypertension medicine, folks who are black, there are certain hypertension medicines that are less bad or that are more bad for you. Right, so if you're black, a calcium channel blocker is better for you than an ACE inhibitor. Usually, it depends on the person, because everybody's really mixed race, right? Like me. So everything depends very much on the person. So instead of doing racist racial medicine, where people are all this kind of people are like this, and all this kind of people like this, instead we try to use studies where we control by race so that we can better understand and target the individual, right? So we break it down. The ideal would be if we could study each person, or each genetic phenotype, or each family, right? We can't do that, so we kind of do groups of people. That's why when you're reading studies, you want to read the population. Make sure they had a good breakdown of men, women, different races, so that it was actually controlled, and that the study groups were controlled by race, right? So they had an equal number of various folks of various, genetic ethnicities in the different groups, so that it's a fair comparison, right? Because otherwise, you don't necessarily know, and ACE inhibitors are more likely to cause swelling or kidney damage in somebody who's black, right? Doesn't mean that every person who's black shouldn't be on an ACE inhibitor. Some people who are black should be on an ACE inhibitor, right? But every person is different. Same kind of thing with black folks tend to be undertreated when it comes to sleep apnea. But sleep apnea is a huge problem that for folks who are at risk of hypertension can increase your risk of heart attack. So why am I talking about these things? Because what I'm saying is when we're looking at studies, we want to try to narrow down to your subsection of the population as close as we can. But the best thing is to narrow down to your family. And, if we could predict the future and be in all timelines, we would narrow it down to you, right? So when we're talking about risks, or when you're anxious about any kind of treatment, look up studies, and look up studies that are done on people that are as close to you as you can find, based on your gender, if possible, based on your race, based on your risk factors, right? Even when we were talking about the pandemic, there was a difference between the average healthy young person and a young American with obesity who was at more risk of dying, right? A 30-year-old with obesity would be at more risk of dying than just somebody else. Your immune system health, the diet you've been eating, all those kind of things affect your risk factors for disease. So who you are matters, basically. So can I predict whether or not TMS is going to be helpful for you or not, based on whether it's helpful for me. No, doctors are not prophets, right? And I am an actual doctor, but my experience as a patient and my experience with other patients can't promise you certain outcomes, right? You have to have an individual session with your provider in order to get real medical advice and stuff like that. But what I can say is I can give you the general information, and then you can kind of make decisions based on that, on what's good for you. So, the evidence for TMS is great. Yes. Which is why I'm getting it myself. Good question. Yeah, absolutely. I can give you study names that you can look up. If you want, there's also a really good, actually the best way to find studies is go to the Journal of Clinical Psychiatry and go to the 2018 guidelines, and then there was a new 2020 update to those guidelines as well. That's good for the U.S. guidelines. There's another set of guidelines, of European guidelines, that was reevaluated and assessed in 2020, February of 2020. It was January 1st, actually, erratum in clinical neurophysiology. There was a January, and then there was a May publication, and that also had a set of guidelines on RTMS. So when you're looking at the European body of evidence, they're a lot more permissive. We tend to think there's a stereotype for Americans where folks think that Europeans have stricter safety standards for things, but actually in a lot of medical treatments, it's the opposite. And there's a little bit more of a, I don't want to say free market, but a little bit more openness to trying certain things in order to keep costs down. And that's one of the reasons that the cost of healthcare is actually so high in the United States, is the FDA as a centralized power for the entire, the United States is almost, U.S. plus Canada and Mexico are a continent, so it's like a third of a continent, right? It's big. So for that big, vast area, you've got one regulatory body deciding what kind of things are allowed to be used. So in the United States, RTMS is only approved for depression. Throughout Europe, it's approved for all kinds of different things, right? Because you're talking about, much smaller countries, and you have a regulatory body per country, and then a lot of these countries are working together, and so things can move a little bit faster. So actually, the United States, with a lot of regulations when it comes to healthcare, actually tends to be more restrictive, but it depends on the topic, of course. It's the opposite for certain women's health procedures. For certain women's health procedures, the United States has the lowest safety standards and is the most permissive, in my opinion, to some pretty negative degree. There's pros and cons to different levels of regulation, right? So if you look at the European standard, they divide evidence for RTMS into a few categories. They have level A, which is definitely effective or definitely ineffective, which requires at least 2 class 1 studies, or 1 class 1 study and at least 2 class 2 studies. Level B is probably effective, which requires at least 2 class 2 studies, or the combination of 1 class 1 or 2 study and at least 2 class 3 studies. Excuse me. Level C is possibly effective, and that requires at least 2 class 3 studies or any combination of 2 studies of different classes, 1, 2, or 3. So a class 1 study in this European journal was defined as a randomized, sham-controlled clinical trial that included 25 or more patients receiving real stimulation therapy with clearly reported primary outcome, exclusion-inclusion criteria, randomized blinding procedure, and statistical analyses, and take into account study bias, and checked heterogeneity of baseline characteristics among treatment groups, which is what I was just talking about. It's like when you control by gender, race, and other things like that. And they check carryover effects, crossover studies, and dropouts. It's interesting that they accept such a low N value, right, as a class 1 study with 25 or more patients. I've definitely seen other standards, like I'm pretty sure Cochrane does not accept the Cochrane review meta-analyses. I'm pretty sure they don't accept studies that only have 25 people as level A evidence. So it's different across different bodies. But what I love about this guideline is they're really open and explain exactly how they're thinking and kind of what conclusions they've come to. And if you look at the guideline, you can look at the different studies that they went over. So, Class 2 study is a randomized placebo-controlled trial of between 10 and 25 patients who got, then they go down. And Class 3 is all other controlled trials with lower methodological quality. And then, but they only use studies with at least 10 patients who were receiving real stimulation therapy when they were making these recommendations, right? So, there's the other one that I was talking about, the big consensus recommendation, was the 2018 one in the Journal of Clinical Psychiatry. And they looked at they did a systematic review and meta-analysis of 29 randomized controlled trials in 1,371 participants. So that's a lot. And they found the statistically and clinically significant pooled odds ratio for response was 3.3, with a number needed to treat of 6. What does that mean? That means in order to get one person who had an improvement in their depression, you needed to treat 6 people. And your odds were 3.3 to 1 of having an improvement in your depression. They also calculated odds for remission, actually. And those odds obviously are a little bit lower, but still very good. The odds ratio for remission was also 3.3, but the number needed to treat was 8. So basically you had to treat 8 people and 1 person would have a response. That's actually a really good number. A lot of our medicines that we have nowadays, you have to treat like 20 people before one of them you're going to see a response, right? So that's really good. 8 and 6 are very, very good. So the evidence is really strong for RTMS in depression, which is kind of exciting, you know? So I like that. And of course they break it down based on which coil is used, and they go into the H1 coil or the figure 8 coil, all this kind of really detailed stuff. So, yeah. Did that make sense? Good. Also, what I was telling you about Europe, basically, is that in Europe, they have found their interpretation of the evidence is level A evidence, so definite efficacy for high-frequency RTMS of the primary motor cortex, M1, contralateral to the painful side for neuropathic pain, HF, or high-frequency RTMS of the left dorsolateral prefrontal cortex, right, for depression, which is what you're here for. Low-frequency RTMS of contralesional M1 for hand motor activity in the post-acute stage of stroke, so that's really cool. And then they found level B evidence for, RTMS to help with things like fibromyalgia, not to cure it, but to improve life, quality of life, or pain, for improving motor impairment or depression in Parkinson's disease, which is, wow, for motor recovery in post-acute stages of stroke. This is all level B, right? So possible or probable efficacy. Level C was possible. So they found it for all kinds of things. They went all the way down. Level B, there was a lot. There was stuff for PTSD. I actually have my computer over here behind you. You saw it. So it's got a whole bunch of other things. Lower limb spasticity and multiple sclerosis. Chronic post-stroke non-fluent aphasia, right, where you have trouble talking. Yeah, just all kinds of things. There's a lot in depression. A lot of depression stuff. Yeah. So there's all different protocols for depression. They can do low frequency, they can do high frequency. It's all aimed towards the DLPC, dorsolateral prefrontal cortex. But there's different areas and things where people try to hit people, which is really interesting. So I think that's pretty cool. So the evidence is good. The contraindications are really only seizure and metal. And seizure is kind of let's talk to a neurologist about it. Because if you are, super suicidal to the point that, we've been trying to work with you with medications, you've had therapy, you've had all these different things, and you're still miserable, we got to ask ourselves, what are the chances that you're going to die from that versus get a seizure, right? So that's where we balance risk-benefit and see if something's beneficial to you. So I have a family history of epilepsy and seizures. And I was on bupropion. I'm not anymore. But, and I think that might be why my psychiatrist took me off of it, because we were thinking about TMS. I'm not sure. But I'm still getting it, and I haven't had a seizure or anything, because I have failed so many depression medications that by this time, this is a good, thing to try for me, balancing the risk-benefit, right? Almost everyone in my family has had a seizure. So, but, yeah. And my providers know that. So that's kind of, we talk about risk-benefit, but again, that's not very common. Most common side effects. So one to talk about is insomnia. Some people have it. So the guideline, the American guideline that I was talking about, talks about insomnia and assessing, how bad is the insomnia? Are you having good sleep hygiene, right? Can we change the motor threshold, which we'll talk about in a moment? Yeah. That's how we figure out exactly how strong to fire the stuff at first, because you start at a low value and then you increase it. And, yeah. That's a good question, yeah. Understood. Yeah, so I had really bad insomnia when I first started the treatment. I already had bad insomnia, right, because I also have PTSD. This is all IRL, by the way. This is all true. I had PTSD. I get nightmares often. I also have sleep apnea. I take medications to sleep, like a lot of them, in order to sleep. And I will say listening to ASMR videos helps a little bit. Yeah. Yeah. So, the first couple days, I had terrible insomnia, and I went in on a Thursday. Friday, I just was incredibly panicked. I get way worse, and I start to get really loopy if I'm not sleeping. And I was like, I'm going to tell them Monday that I don't want to do this. Because I was also I was just having not a fun time. But now, 30 days later, I'm sleeping normally again. So, and it didn't take 30 days for it to normalize. I talked to the doctor right away that Wednesday, right? It was Thursday that I was miserable. I told the lady on Monday, I don't think I ever want to do this again. Can I talk to the guy Monday because I'm having a bunch of side effects that I wasn't really anticipating. I talked to the doctor, and he was really understanding. He sat down with me, and he was like, this is what's, he listened to my situation and he was like, well, if it doesn't get better, then we'll just stop the treatment. That's totally reasonable. Well, it did get better. My mother-in-law kind of encouraged me to, like, stick with it. And then I have a lot of faith in science, and I knew these studies existed. So my thought process was like, look, it's worth it to get better, right? I want to get better. I've been having terrible depression for years. I want to go out there and live my life. What can we do to, move forward? So, so that got better. But I did have insomnia at first. And most people don't. In his experience, the most common side effects people have are a little bit of tenderness or discomfort at the site where the magnet is, like, pop, 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 pop. You're not actually being hit by a jackhammer, but it's sound. I have a lot of nerve sensitivity because of fibromyalgia, and it's like, you'll hear it when we turn it on. It's like this tapping. Maybe some people like it, right? I'm sure there are people out there who like the sound of it, but it's pop, 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 pop. And then, people have sight sensitivity because it's a magnet that's like, bump, 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 bump. It feels like something is tapping your head, and that's probably not a big deal for most people. With the fibromyalgia, I'm very sensitive. So some people have some discomfort. Some people have headaches. I had a lot of headaches at the beginning, but not bad headaches. They were like tension headaches. The first 2 weeks of the treatment, I was like so exhausted. I felt really tired after each treatment, but I couldn't sleep at night, and I was having headaches. I felt miserable. I have to say, 4 weeks into the treatment, I am feeling more energy, and it feels like there's something missing in a good way. Like, I don't, knock on wood, as they say, although I'm not superstitious, but I'm happy with the results that I'm getting. Like, that underlying misery that's been my constant companion for years, it feels like it's missing in part or in whole. So we'll see. I'm curious. I'm not done with the treatment. You have to finish the treatment. If you don't finish it, your chance of remission is lower, right? If you finish it, it's more likely that you're going to make the depression go away, right? You have to do the treatment properly. You have to do 36 sessions. I have done 20, right? Because there's weekends and holidays and little things. So, and I'm sleeping normal again. And I'm not having, I was tired. But it's kind of like, like if a cancer patient is getting chemo and they feel miserable while the chemo is trying to fix them. It's kind of like during the first 2 weeks, I knew something was changing, like something was happening. I was having a lot of irritability, and I was feeling feelings that I hadn't felt in a while, that I had kind of pushed down, and I felt so overwhelmed because a big part of both PTSD and depression can be a numbing, and then I was feeling all these things again. I was like, I don't want to feel these things. I don't want to deal with it. But part of healing is getting into the wound and dealing with it. So I'm actually really glad that I've stuck with it. So we'll see what happens. But most people don't have as difficult a response as I did. It's pretty clear, compared to the side effects with depression medications, compared to, the numbers needed to treat for depression medications, compared to the failure rates with depression medications. I mean, the evidence for RTMS is so good, and I believe in science, right? I have a lot of faith in science. So headache, sometimes neck pain, some of that discomfort at the site, right? But you can always put a, balm there, like you can put on some tiger balm, you can put a little hair loss. No, it's not an actual thing touching you. It's That's a magnet. I'm just very sensitive, so to me it feels like it's tapping my head. For the average person, it's not going to feel like that. So, people who are bipolar, just like with a certain medications, right? You can induce a manic episode, so that's somebody who probably shouldn't have TMS, and sometimes you might not know if somebody was bipolar, so you watch for the kind of manic symptoms. Hearing loss or tinnitus, that's rare, but you want to be keep your headphones in, or keep your earplugs in, right? Yeah, it's just because it's that same sound over and over again. So, fainting. You want to check your, you would go to a cardiologist or back to your PCM if you had anything like that. It is a possible but extremely rare side effect. The tech that is taking care of me, I don't think she's ever seen a single case, and she's taking care of, many, 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 many patients on that. The most side effect she's ever seen is headache. So that's anecdotal. The big evidence is the studies that I was talking about, but even the anecdotal evidence is good, right? She's never seen that. So, and then of course my personal evidence, I didn't faint. So, just kind of talking to you as someone, straight up, as someone who has experienced the most difficult part of it. Not the most difficult, right? I haven't fainted or had a seizure, which again, extremely rare. But as someone who had a rougher go of TMS than a lot of people did, I'm not going to push you in any direction, but I will tell you the evidence is good. I'm glad that I stuck with it. And I really didn't think I was going to, because I don't like things woodpeckering on top of the nerve that runs right here, because that's the other thing, is there's a nerve that runs right here. Well, you have to get into, so in the front part of your brain is where, the dorsolateral prefrontal cortex is. The frontal cortex is where a lot of your thinking happens. And so in order to get there, it's a part of this motor cortex strip that we're trying to hit, right? It's close by to there. And so in order to get in there, well, there's stuff in the way. There's skin, there's nerves, there's a skull. And it just so happens that in my case, a very sensitive nerve runs there down to my nose. So when it's stimulating my brain, the waves are hitting this nerve on the way. So it feels really like along that nerve, like itchy. like it's like, ee. That also improved. In fact, I told her today, I can tell when it's time to increase the intensity because it no longer feels annoying. And so I'm ready to move up to the next level. Right. If that makes sense. Yeah. So that's it. And when you compare it to antidepressant medications, right, where you're looking at things like worsened suicidality, random death, cardiac effects for some of them, definitely seizures for some of them. When you're looking at things like, even affecting your libido, affecting, and all of these side effects are worth it if you can keep you from dying, right? I am currently on Savella. In the past, I have been on bupropion. I have been on duloxetine. I have been on fluoxetine or Prozac. I have been on, I was on Effexor, which I hated. I hate Effexor. And I don't like the studies for Effexor because even the studies by the pharmaceutical company were compared to the placebo. So the placebo improved depression in 50% of people. That means the sugar pill. Just taking the pill and knowing that they were doing something that was good for themselves helped 50% of people to feel better with some of their depression symptoms. and 75% of people got better on Effexor. So it's only a little bit better than the placebo. And you see why, like, I'm not excited about Effexor, but I am excited about TMS, right? One benefit with medications over something like TMS, well, there's two. One of them is it's easier to placebo a medication, right? It's hard to placebo. It is possible to placebo or sham a procedure, right? They could put something else on your head that goes tuk, 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 makes a loud sound, and so that you think you're getting a treatment. They can do that, but it's definitely easier to make a sugar pill. The other benefit medications have is initial upfront cost. Yes, so TMS can be pretty expensive for a full set of treatments, but if you're talking about someone who they're probably going to die if they don't get it, medication cost over time can be very expensive, right? You're talking about every day for months and months. On average, you have to be on the antidepressant medication for a year for an episode of MDD before you can start to think about coming off, right? Because that's how long an untreated episode can last if it doesn't kill you, right? And some of us have had depression for much, much longer, right? And so you're talking about an extremely high cost of continuing to pay for those medications all the time. So in that case, right, you know, the military, the VA, the federal government has already spent thousands of dollars on me and my treatment. You're talking about hospitalization. When I was hospitalized for 30 days back in 2018, I think my hospitalization was like $60,000 or something. It was something crazy. Something very expensive, right? So when you start looking at those costs, then a $6,000 cost for, 36 TMS treatments tends to start looking a lot cheaper. So really depends on what your insurance will cover. I'm getting it through the VA. Yeah. And sometimes you have to keep pushing before you can get what you need. Sometimes you have to prove to the insurance company, like, I failed this, and then have your doctor write a letter and send you to where you need to go, right? And then it gets covered. But it can take a little bit of pushing. You have to be willing to push for yourself, though. If you're in a socialized healthcare system, same thing. Sometimes you just have to push, and sometimes it can be harder to get those things there because people are encouraged to keep costs down and to give you what's cheapest. But you just push. You say, look, here's the evidence. Here's what is in the European clinical guidelines. I've failed this and this. Please help me get this. Please refer me to the right source to get this paid for, right? And then, if you really can't find anything, there's always clinical trials that you can try to get into. But cost is a thing. But again, what's the long-term cost of staying sick? In someone like me, you're talking about lost work time. You're talking about things like hospitalizations, which are very expensive, right? Somebody that is getting this severe, are we really saving money by avoiding a treatment that has really good evidence for it? Are you really saving money? Or are you going to die? So that's how I feel about TMS, based on the evidence and information that I've got. Do you have any more questions for me? I see. That is a good question. Factors that have been correlated with a decreased response to RTMS include mood disorders with significant anxiety, longer depressive episode duration, but both of those things, neither of them were consistent predictors in big trials. In other words, it doesn't mean you're not going to get better. Comorbid psychotic symptoms, so like seeing things that aren't there, hearing things that aren't there, was also associated with a decreased efficacy in some studies, but that same thing exists for antidepressant medications and other treatments as well. It's just harder to treat that kind of depression. So, and depression with psychotic features has not been extensively tested, to my understanding, in RTMS. So, yeah, it can range in costs between $6,000 and $12,000, but you can kind of look around. So, and again, it's less expensive also than electroconvulsive therapy, which is another actually useful option. Yes, that's like, not like old days scary stuff. I've actually sat in on ECT therapy and had friends who got it. But we can talk about that some other time. Nowadays, it's very civilized and not all barbaric and scary. And again, the studies are good for it. So nowadays, what people do is you're sedated and put to sleep, just like for a surgery. And then you get a couple quick ECT shocks. And there's no like scary flailing or shuddering because everything's sedated. And then that's it. And then, that's the treatment. It's much shorter than a TMS treatment, actually. And it's safer for pregnant women who have failed a lot of antidepressants and don't want to harm the fetus. So it's but it's definitely not first line. We usually start with medications, and if somebody has failed a lot of those, then we might talk about ECT therapy. But again, it is still an evidence-based treatment, actually. People in the news and in movies like to make that kind of thing scary. And I definitely know for myself as a patient, I had a lot of anti-psychiatry bias because we're still taught, like in college psychology, people are taught all kinds of BS. Like just the stupidest Freudian BS. And anyone with a brain can kind of see through Freud's BS and see, like, that is ridiculous. Like, the edible symptoms and stuff like that, absolutely BS. No evidence for it, right? Nobody uses Freud in clinical practice anymore, okay? So there's a lot of, and I think pop psychology, pop psychiatry, and movies and TV promote a lot of falsehoods about mental illness, and they can also promote a lot of falsehoods about mental illness treatments. So, but no, RTMS is not like electroconvulsive therapy, which again is more expensive. You don't have to be sedated. It's not painful. You don't have to, it's not as physically draining and exhausting. It's nicer. It's much nicer. You just sit in the room, and you'll see. You just sit in the room, you listen to your music or your ASMR or whatever, and then for 30 minutes, and then you go home. So it's not dramatic like that. Yeah. Good question, though. When you are thinking about cost, yes, the more antidepressant medications you have failed, the less likely you are to maintain remission with RTMS. So, that's a factor too. It's kind of the same with anything. The more treatments you've failed, the harder it is going to be to treat you. One of these things is telling me that, like, folks who have tried and failed, like, 2 or more chances of achieving remission and then maintaining remission for 12 months is low. But I feel like just achieving any kind of response and then coupling it with therapy, like what I'm doing, I will take any response. I know that my chances maybe of being normal might be low, but I would rather be more functional and feel, 50% better than continue to feel miserable. And here's another way to put it. I would rather feel better for 8 months and achieve something, some kind of improvement, than not try and just continue as is, right? So, but there's a lot of other factors in my case, right? Like in my case, I'm also getting therapy, and then I'm also going to be trying another kind of interesting treatment. Yep. I'm trying everything. So, but in someone like you, with less risk factors and less of the long history that I've had, your chances could be better. So it's definitely something to think about. Absolutely. Any other questions for me? There is a shorter version of our TMS called ATMS, and that is cheaper. It's called an accelerated TMS protocol, and that's something you can ask for. And that can address the cost issue, especially if you are someone like me who, you need to try something else. You've failed multiple antidepressant medications, but you are concerned about the cost and a decreased chance of the thing working for you versus somebody else, right? Yeah, exactly. So then you can ask for like an accelerated treatment program. There is a meta-analysis in, is it the journal? It's the Journal of Psychiatry Research, and that was in 2019, March. Sonmez, Dr. Sonmez, Sonmez, and everybody else. They said the title of the meta-analysis is called Accelerated TMS for Depression, a Systematic Review and Meta-Analysis. So that's one you can look at. And it evaluated the studies that currently exist for normal TMS versus accelerated TMS, and there are protocols you can do to accelerate it. So that's cool. So, if that's a way to address the situation, especially cost as a factor. So, yeah. Any other questions for me? You're asking a lot of good questions. I hope I've helped a little bit with the anxiety of when you're thinking about treatments and, how they work and which ones to choose for yourself. It's good to have a clinician that you're working with who's working with you, who can help you navigate these things. I do health coaching in real life. I'm a physician and I have my own patients, but for folks who are not my patients, but would like help figuring out some of their, navigating the healthcare systems and doing self-care and figuring out what they want to do with themselves, healthcare.byjenfinelli.com. I do help people kind of navigate healthcare systems and figuring out how to research stuff for themselves in depth like this. Yeah. But yeah, talk to your provider if you have questions. Yeah. Because I'm not the one making the final decision about your treatment. I'm not making any decision about your treatment. This is not official medical advice. Because you and I have never had a meet space, IRL, individualized session or evaluation. But I do want to provide you with real information. Shall we proceed? You want to see what it's like? Okay. So we're going to do now, I'm going to have you, I'm going to put pillows under your arm here. So I'm going to get up over here and I'll put pillows under your arm. this is just to be comfortable. I'm going to have you fold your arm up, hold your arm up like you're giving a thumbs up. Just like this. Just like this. So you'll just lean on the pillows there. The reason for that is I'm going to look at your finger. I'm going to look, and I'm looking for twitching. Basically, I want to find out. You're gonna kind of feel tapping, and the tapping, we're trying to figure out where your motor threshold is, because that helps us determine the strength of the magnet to blast at you, basically. Blast is really the wrong word. So, to poke you with. So, we're looking for twitching to see if, since we're talking about the motor cortex, we're looking for twitching to see what strength causes your finger to twitch, basically. And we want to just ease off before that. And then we calculate motor threshold. We start at 80%, and then over the course of the 36 treatments, we move up to 120%. So, alright, so go ahead and close your eye. You're going to feel a tap. You're going to feel a little bit of tap. Okay? And another tap. And, oh, it looks like we're right there. You can open your eyes now. I just wanted you to have your eyes closed so that you wouldn't mess with the tapping. So you wouldn't trigger your thumb moving. So if you like, some people put earbuds in, usually hearing protection. If you have, the ideal to have is if you have sound controlling headphones, right, that make it so there's no outside sound, that's the ideal. Yeah. Well, that's perfect. Yeah, you can put those on, and then alrighty. Have a wonderful session.